This topic is about bronchiolitis and respiratory syncytial virus, also known as RSV. Respiratory syncytial virus, also known as RSV, is caused by a virus. It's right in the name. So let's talk about exactly how this virus affects the lungs. Inside of our lungs, we have small airways, also called bronchioles. They look like small little tubes. So this mucus that is typically able to pass through these small airways or tubes in the lungs is no longer able to due to the increased inflammation and the thickness of these secretions. So due to the combination of the increased inflammation in the bronchioles or small airways and the thick mucus production, this causes an overall obstruction in these airways and the client then has difficulty breathing. So this virus, as it's implied in the name, can be spread through respiratory droplets. But what we don't typically think about is that RSV is unique in the fact that it can also be spread by direct contact or sharing items that have been contaminated. This virus most typically presents in the winter and spring months. So how do we distinguish that this virus is in fact respiratory syncytial virus over another? This test can be performed via nasopharyngeal swabbing, also known as a PCR that detects the specific virus. This is just a nasal swab that we'll send off to the lab and it'll detect whether RSV is present. So who's at the highest risk of being infected by RSV? Typically, with any infection, we say that the youngest and the oldest populations are at highest risk, and that stands true here with RSV. Infants under the age of 6 months are at highest risk for any complications or severe illness. Also, our immune-compromised population. Their immune system is not as matured and ready to fight these infections, so because they have more suppressed immune system, they're at higher risk of having severe illness or complications. Secondhand smoke exposure can also be an issue and risk factor for RSV. Secondhand smoke just means that the child themselves is not smoking, but they are exposed by another person who is smoking in close proximity to them. Smoke can cause inflammation in the airways, including those small bronchioles or tubes within the lungs that we discussed earlier. So due to the fact that this respiratory virus causes increased inflammation, and you put that in combination with the smoke that also causes inflammation, this usually causes further issues. And of course, any child who has any underlying diseases, specifically a pulmonary illness, such as asthma or cystic fibrosis, are absolutely going to have further complications with RSV. Their lungs are already compromised and they already have sick lungs. So putting another virus on top of that, which will cause more mucus secretion and more blockage in the lungs, will cause them further complications. So we discussed populations that are at higher risk for severe illness, but any child of any age can actually acquire RSV. And there are different levels of severity that this illness can cause. So RSV can present a lot like a cold. You can have rhinorrhea or a runny nose, cough, typically a productive cough due to the increased amount of mucus secretions. You can also have pharyngitis or a sore throat, which is typically caused by the increase in secretions that causes inflammation and irritation in the throat. You can also have increased sneezing and fever. Now, how do we determine that this is different than any other cold? With a cold, you typically call it actually a head cold. You see all of your symptoms up here, so you'll have the runny nose, possibly some headaches or stuffiness. With RSV, this is more of an issue of the lungs, so we're seeing issues with the coughing, the mucus production, and difficulty breathing. Now, speaking of the lungs, let's talk about what you'll hear when you're listening to a client with RSV. Typically, you can hear any type of adventitious lung sounds, which just means extra sounds in the lungs, whether that be wheezing or crackles. And just remember, with RSV, each time you listen to your client, it may sound a little different each time because every time they cough, they're moving around that mucus and exercising their lungs a little bit differently. So it's okay if you don't hear the same thing every time, but just know it's possible to hear extra sounds. So the course of this illness is also unique in the fact that, yes, it can typically last about 7 to 10 days as other colds or viruses, but this one gets worse before it gets better and typically peaks around the 5th day of illness. So how do we know to prepare clients and their families when it's time to be hospitalized or seek further care when they have RSV? Well, typically we say you'll see a change in their breathing. So this is closer to that 3 to 5 day mark where the illness has progressed, the mucus is very thick, and the secretions are high. You can see hypoxia. You can also see an increased work of breathing. So the child may be grunting, using accessory muscles where you can see their shoulders moving with each breath. You may also see retractions in our young infants, where you can see the ribs each time they take a breath. They may also have an increased respiratory rate. All of these signs are indicators of respiratory distress, and clients should seek a healthcare provider immediately. Now, as you may know, infants can have what we call apneic periods, where they breathe really fast and then take a while to catch their breath, where they don't seem to breathe for about 20 seconds. But these periods can be exacerbated in RSV, and that's when we want to get concerned and seek a healthcare provider. Now let's talk about how we can best care for our clients with RSV. Again, this is on a spectrum of mild to moderate or even severe presentation of RSV. Typically, once clients get hospitalized, we're seeing more of the moderate to severe clinical features. Now remember, when you're taking care of these clients, make sure that you remember that contact precautions are very important to incorporate, not only just droplet precautions. So we're going to make sure we're decreasing the spread of this virus by wearing our gown and gloves, as well as a mask. So let's talk about some of the other interventions that we can implement for clients with RSV. We also want to administer IV fluids, not only to keep our clients hydrated, but this can also help thin out those secretions and help them cough them up and move them around. But most importantly, we want to make sure that we're monitoring our clients' oxygenation status. So we want to make sure their oxygen saturation is over 90%. And if our client is not able to maintain that on their own on room air, we need to intervene and maybe give them some oxygen. Our clients may also be experiencing fever, so we want to monitor and treat appropriately with acetaminophen or any other antipyretics. And because these clients are experiencing such thick secretions, we want to make sure that we're helping them with that. A lot of infants are not strong enough to cough this up or cough it out. So we want to make sure that we're suctioning as needed to help them with those thick secretions and help relieve any respiratory distress. Now, how do we monitor these clients? Well, we want to make sure, again, that they're hydrated, so monitoring their intake and output. And by monitoring their intake and output, we want to assess for any signs of dehydration. We also want to monitor our clients' activity level. Of course, kids aren't going to be as active when they're not feeling well, but it becomes concerning when they become lethargic or listless. These two things can be signs of decompensation, and this means that our child is no longer able to compensate with their own reserve, and we need to help intervene. We also want to monitor for secondary infections. Due to the amount of thick secretions that RSV can cause, bacteria love these dark, moist secretions, and it can be a great feeding ground or medium for them to grow. Therefore, we want to make sure we're checking for any signs of pneumonia or even ear infections, also known as acute otitis media. So we've touched on a little bit of describing respiratory distress and the symptoms that go along with that. Let's talk about it in more detail and really break it down so you can become confident in your assessment. So there are multiple signs of respiratory distress, but we'll talk about some of the most common. So tachypnea can be a classic sign of respiratory distress. This just means our client is breathing at a faster rate than their baseline. We can also see hypoxia. Our client's oxygen saturation is dipping below 90%. We can also see accessory muscle usage. So, like we said before, when they take a breath, we can see our client using their muscles to help bring in that breath and breathe out. We can also see retractions, which can present in many different areas. You can see pulling right here in their neck. You can also see pulling or their ribs whenever they take a breath, right here by their abdomen. We can also have nasal flaring, which is another indication of respiratory distress. There are multiple interventions that we want to use whenever we know any respiratory distress on our assessment, but positioning can be a great way to help. If we help our client sit in a 30 to 40 degree angle, that'll help open up their airway and allow them to breathe easier. We can do this either by nasal cannula or high flow. High flow is just a positive pressure system that helps pop open those small airways and improve oxygenation. We can also add moisture to the air that our clients are breathing. And whenever we add warm humidification to the air our clients are breathing, this helps decrease or thin out those secretions and helps them cough them out or move them around easier.